Good morning, everyone. My name is Keith Morse. I'm a pediatrician here at Stanford, and along with Dr. Natalie Pagler, co-chair for this morning's program. It is my distinct honor to introduce this morning's keynote speaker, Dr. Ricky Choi. Dr. Choi currently serves as the head of digital health at Samsung America while maintaining a clinical practice in pediatrics here at Stanford. He completed his medical school training at the Medical University of South Carolina, a master's in public health at Harvard, and a pediatric residency at UCSF. Dr. Choi is a leading voice in the power of digital health to improve patients' lives. Here at Stanford, he co-leads our Pediatric Digital Health Task Force, and globally advocates for the role that smart technology can play in personalized health and wellness. And yet, he will be the first to tell you that technology is only a small piece of what it takes to deliver high-quality patient care. He advocates for a holistic approach for using technology to empower patients, their families, and their communities. It's an honor to have Dr. Choi with us this morning. Please help me in welcoming him to the stage.
Well, good morning. I am so excited to be here and to be with all of you. When I look at the people in this room, and I just think, okay, we're going to be part of the same family, thinking about these really hard issues because we're all really passionate about improving child health. And I hope that in future years for this conference, we're going to just fill this room to the point that's standing room only as we continue to advocate for the lives of children. Just a couple disclosures. As mentioned, I work at Samsung Electronics America. My comments represent my opinion and positions, and my opinion positions, and not those of my employer. So my daughter graduates from high school this Friday. She's off to college this fall, and it's really been a moment of reflection as I thought about the different things that have been influencing me in my life and in my thinking. And over 60 years ago, Thomas Kuhn wrote The Structure of Scientific Revolutions, in which he outlined his theories about how major changes in science occurred. Think about the transition from the geocentric model to the heliocentric model in the solar system. Think about the transformation of physics from Newtonian mechanics to Einstein's theory of relativity. And he argued that progress of science as being heavily influenced by social context. According to Kuhn, these changes were the result of new questions being posed that could not be addressed by the paradigm of the day, and ushering in of new models to address those questions, or what we commonly call a paradigm shift. So in this quote, he describes the kind of people who would usher those changes as people who are not bound by traditional rules, so much so that they could start to imagine this new model. And for me, it inspired me to think about fresh perspectives for new ways to solve old problems and to take an interdisciplinary approach to solving those problems. Now, in a recent conversation with John Brownstein, the Chief Innovation Officer of Boston Children's, John said, in the near future, AI will transform pediatrics. For patients, accessing information, getting matched with the right provider, making an appointment, getting a second opinion. After discharge, an engagement AI will be a constant touch point with the human in the loop. Hospitals will have AI co-pilots for billing and documentation, and not only will this happen, healthcare needs it to happen. Ushering in this kind of transformation will require people with an openness and boldness to bring about this new paradigm. So I became very interested in the role of consumer technology to improve health when I saw how my patients use them. For nearly 10 years, I was the head of pediatrics at an FQHC in Oakland, which saw largely new immigrant populations. And I had patients who didn't necessarily have enough money for Christmas presents for their kids, but they all had a smartphone. And this is back in the early 2010s. Families in the margins were using technology to stay informed about the world, to stay connected with loved ones, both locally and abroad, to go to work and go to school. It became clear to me that digital technology is a super determinant of health. Consumer technology is designed to be easy to use. It's configured for engagement, and people feel empowered when they use it and see the value in their daily lives. and it puts consumers in the driver's seat. So working in consumer tech gives me a front row seat in the way AI is already impacting lives. We may ask a virtual assistant for the weather forecast, or you may have used it to get the fastest route to this conference. We get served with personalized recommendations when shopping or browsing streaming movies. We get ideas for vacations from ChatGPT. We use predictive text to help us write our emails faster. In digital health, we've been thinking about how to use this data exhaust generated in our daily lives towards helping people better understand their health status, becoming aware of risks of health, and as well as getting connected to care. And it starts with developing the next generation of biosignals from common devices like rings, watches, and earbuds, using machine learning to develop predictive analytics about a user's health, to improve the signal-to-noise ratio. We're now measuring things that in the past could only be measured in the four walls of the hospital. Health claims from these technologies had advanced to the point where we're meeting regulatory scrutiny with software as a medical device designation for tools to address problems like sleep apnea and atrial fibrillation. However, we all know that vital signs in isolation are just not that helpful. We need context. We need personalization. We need behavior change elements to motivate people to develop new healthier routines. And so consumer technology is looking at AI as a health coach to help people achieve their health goals. We're also linking them to interact with the environment in the home. As a physician leader at Samsung, I'm thinking about how do we tie in that TV, the Internet of Things, the appliances and wearables towards understanding health status, understand people's needs, and help them achieve their health goals. And this is all generating a vast amount of data, which will require the power of AI to make sense of. We're all imagining a future of automation and care support that includes preventing or responding to falls, all the way to sensing changes that may require escalations. Like with a smart fridge, for example, I can sense about changes in my mother's routine. The average household opens a fridge about 30 times a day. So if I'm noticing a change that she hasn't opened the fridge for a few days, or the camera inside the fridge shows that the contents haven't moved, then maybe that's a signal that I should reach out and check in on her. So as digital natives, we know that children are already living in an AI-enabled world. And parents, many of whom are millennials, are digital natives themselves. And from observations of my patients, as well as my 3 kids, 2 of whom are teenagers, they're using AI to connect with their friends, to get recommendations on music or on TV shows to watch, generating ideas about school projects. My kids were studying for AP tests about last month. And so they would ask ChatGPT, pose questions that I would get asked for my AP European history test. They would respond in the prompt and then ask the ChatGPT to evaluate their answer based on what they submitted. They're way ahead of us. Now, in this Common Sense survey, it shows that over the years that families have been, in the Common Sense survey, it shows that 70% of teens have been using at least one type of generative AI. As you would expect, help with homework, as well as to stave away boredom, as well as translate between languages. But they're all using search engines. They're using image generators and et cetera. So over the years, we have seen how families seek information about health concerns and show up to clinic more armed than ever with information. We saw this information-seeking behavior when Dr. Google seemed to join all of our clinical practices about 15 years ago. We saw how much anxiety it created for our patients. Everything seemed to lead to cancer. And now today, teens are using ChatGPT to answer their own health questions and to seek advice. And they can come to us with a differential that might even match the level of an intern. It's impossible to avoid because generative AI is now integrated in web searches. It's at that top bar that offers those AI overviews. And so it feels like the provider's role is changing. It feels increasingly like patients aren't consulting us. They've done their search, they've arrived at a conclusion, and now they're just informing us about their conclusion. Now, to be fair, there's still a bit of skepticism about generative AI. In a Deloitte survey of about 2,000 adults, only 37% of consumers use generative AI for health reasons, the main reason being lack of trust, and doctors continue to be the authority in terms of health for adults. But as health technology continues to improve, it's not hard to imagine that in a few years, patients will be turning to chatbots with more personalized and more accurate results. So when I think about technology, especially in a business role, I'm always thinking about the problem first. What's the problem I'm trying to solve? So let's look at healthcare for a moment. And as you may know, or as you all expect, satisfaction with the US healthcare system is quite low. We all know that the healthcare system falls way short when it comes to achieving the quadruple aim, but I find that this perspective from the patient really clarifying. So if you look at that bottom bar, and I know it's really small, to put it another way, 73% of those surveyed are saying that healthcare is not meeting their needs. And for the reasons that we kind of know already. It's too expensive. Their health insurance doesn't cover it. They have a hard time navigating the system. The system is too focused on acute care and not enough on preventive care. And in other contexts, this would be, or any other industry, this would be catastrophic, right? When we think about comparing to industries like banking, or we think about tech, or we think about entertainment, the health industry seems the slowest to change. And there are a lot of reasons for this, but I would argue that there's no other industry where improvement is more critical. So let's look at child health. And again, I bring this up to just remind us about the problems we're trying to solve. As all of you who are child advocates or are in child health, you know that have seen the rise in asthma and diabetes, as well as obesity, where a third of children and adolescents are either overweight or obese. 20% have special healthcare needs. The epidemic of mental health challenges, where 42% of high school students feel sad or has struggled from loneliness. We talk about the 8.3 million with anxiety and depression. And we all know that how sensitive children in particular are when it comes to socioeconomic status. We think about insurance. We think about the kids and the kids who do and don't get their annual well-visit checks, as well as the problem of child poverty. And this is all in the context of many challenges happening in the broader healthcare system. We think about provider burnout. We think about workforce shortages. It's estimated we'll be short by 100,000 healthcare workers in the next 2 years. The high cost of care, and ironically, the poor outcomes we're getting for that high cost. So parents are using AI for different parts of their lives, and so the question I'm asking is, well, do they want doctors to use AI in their child's health? There are a handful of studies on this, but one study looked at caregiver opinions on doctors using AI. They surveyed the caregivers of children presenting to the pediatric ED with respiratory complaints, one of the most common complaints in the ED. And 87.9, so near 90%, were extremely or somewhat comfortable with the use of AI in the decision for blood and viral testing. And similar numbers for chest x-rays. Maybe a little bit less, but still a vast majority around determining the need for hospitalization. And 93.5% wanted to be aware if AI was being used in their child's health. And this is consistent with other studies. What's interesting is the most common benefits perceived in the healthcare were in making diagnosis faster, finding things that a human might miss, and helping doctors and nurses spend more time with their patients, which I thought was really interesting. It's something that we as physicians certainly are interested in. And the concerns being around making mistakes in diagnosis, causing doctors to miss details or suggest the wrong treatment. Now, all too often, we don't actually ask what children think. And there are very, very few studies on this, but one I did scratch up was this one, where it was a survey done, a national survey of 171 children and young people surveyed some UK schools and university students on AI in general and specific use cases, specifically around bone fracture. 42% felt that AI would be more accurate at finding problems on X-ray than humans. 71.3 agreed or strongly agreed around wanting to know the accuracy of the tool, feeling that accuracy was more important than speed, so a little different, I think, than what we hear from other groups. And 64.3% saying that AI should be used with human oversight. So given these range of needs, so many problems that we need to address, we can imagine a range of ways that AI could be used to improve child health, from risk identification to decision-making, from diagnosis to management, from prevention to health literacy to education, and addressing social determinants of health. From the business of medicine to healthcare workflow and drug development, I think this diagram really nicely encapsulates the key considerations when it comes to AI in pediatric healthcare, including ethics, including data security, the lifetime impact of these technologies and the data collected, data adequacy, and medical privacy. And there is some progress to report about when it comes to AI in child health, and I think we're going to hear a lot more about it from the other speakers this morning. In asthma, there have been algorithms developed to predict the likelihood of developing persistent asthma, as we know that only a subset of those who wheeze at a younger age go on to develop persistent asthma. There are machine learning algorithms developed that combine clinical data with SES data, influenza patterns, and the weather to predict hospitalization. There are advancements in autism, and I think we'll hear more about that today. There's an FDA-cleared solution that uses data from the caregiver and the provider, as well as video of the child to diagnose or rule out autism in children thought to have developmental delay. One of the values, of course, being the speed to diagnosis. And there are tools in early stages of development and validation within neonatal jaundice detection, symptom checkers, mental health screening, obesity prediction, and cough analysis. As was mentioned earlier, in radiology, AI has been used to detect injuries, as well as fractures, and quantify scoliosis, therefore shortening scanning time, decreasing radiation exposure, and decreasing the need for sedation. But even beyond this, some would say that AI has even developed to the level of clinical reasoning of an expert clinician. But before getting to the real transformative advances, leaders at major children's hospitals are telling me that their current focus on AI in their hospitals is on the boring stuff. And some of that was alluded to earlier today as well. And this is consistent with surveys of physicians in the areas of greatest interest while low in risk. High-need areas like physicians' daily task and administration through intelligent automation. And so most commonly, we'll find ambient scribes as being launched here, and other tools to decrease burnout and drive efficiency. Using intelligent chatbots to automate invoice management, technologies to reduce medical errors, internal LLMs to guide new clinicians on care pathways and protocols, machine learning models to decrease no-show rates, and et cetera. Now, I think as one of the things that was mentioned a little bit before, I think that one of our biggest concerns is that kids are being left behind. And we think about, when compared to advances in technology for adults, we're seeing a lack of investment and not the revolution that we're hoping to see from all stages. When we talk about building technologies, investing in technologies, and implementing them as well. And what's really ironic, as I alluded to earlier, is that children and the parents of this generation are some of the earliest to adopt technology. And there are a lot of reasons for this, and just to go over some of them. So child health is not viewed as an attractive area for attention or investment. Digital health technologies in general are adopted to drive cost reduction or to drive new revenue. But kids only represent about 10% of the healthcare spend. It just does not feel like a big enough target from a business perspective. Over 50% of pediatric care is covered by Medicaid. We know that Medicaid reimburses at a lower rate than Medicare or the commercial counterparts. Preventive health is a cornerstone in pediatrics, but as we know in our society, is not prioritized, heavily underfunded. And from a data perspective, and data is so critical when we talk about developing these algorithms, there are many obstacles. And there are significant differences when we talk about children at different ages, and so we have to think about how do we then segment that data by age, and therefore leading to smaller data sets. And then when you start adding characteristics that we care about, when we talk about race and we talk about ethnicity, SES, numbers get even smaller. According to the American College of Radiology, only 3% of AI algorithms approved by the FDA were intended for pediatrics. Pediatrics also includes the discovery and treatment of rare and uncommon diseases, and again, this goes back to just less data and a lack of diversity of those data sets to train on. In terms of safety and security, there's a very high bar when it comes to digital tools for children, and rightly so. In addition, some of these laws and regulations vary state by state. And so for developers and investors, all of those just look like barriers, versus when you're thinking about developing for an adult, where you may have fewer constraints. And in addition to the lack of data after segmenting by age or disease, We have to think about designing those technologies for those different age groups, because the need of a 3-year-old is going to be different from a 9-year-old or a 15-year-old or an 18-year-old. And we also have to think about designing for different personas and settings. As dependents, children are being cared for by different guardians, whether it be parents, grandparents, aunts, and uncles. The technology has to be designed for different personas as well as different settings, whether you think about the home, think about the school, as well as the clinic. And unfortunately, the data doesn't necessarily flow between those places as well. And so we have seen how these factors have slowed the development in terms of medical devices for pediatrics. There's a long history of lag when you think about children versus adults. This graph shows that of 876 AI/ML-enabled medical devices marketed in the US from 1995 to 2004, as identified on the FDA website. So they basically divided up those different devices by those who are for children, or those under 18, versus those for adults, or did not mark specifically that it was for children. Most common use cases being for radiology and cardiovascular disease. So as mentioned before, children are under-targeted for advances in healthcare. And so now the added concern, as was mentioned, is the off-label use of adult technologies that have not been trained on, have not been tested or approved for children, and obviously then can introduce harm. And we see this off-label use when we talk about drugs, we see that in medical devices, and now we're starting to see that in digital technologies and in AI. There are approaches by the FDA and others to try to ease some of those challenges, but there's a lot more work that needs to be done. So we've been talking about the parents, we've been talking about the kids, and now I think it's really important to think about implementation and adoption of these technologies and acceptability when it comes to physicians, and specifically whether or not doctors are ready. Because if we're really hoping to usher in this big change, a new paradigm to address child health, providers have to be on board. And as a primary care physician, and given that the large part of pediatrics is primary care, I've been thinking a lot about what are the opportunities in primary care. And so I've been involved in a number of conversations in a collaborative between the AAFP and Rock Health to explore this potential for AI and digital health to address challenges in primary care. And so they conducted a survey last fall, about 1,200 respondents, largely FPs, with some pediatricians. They didn't actually ask if those FPs see children or not, so that's just a caveat. But I feel like this is probably the best proxy when it comes to for pediatricians. Now, nearly all of those surveyed use digital tools. And not surprisingly, most common was the EHR, followed by clinical decision support and patient engagement. But when it comes to AI use, especially for personal use, 62% said they use generative AI tools like ChatGPT in their personal lives. And of those who haven't, 80% expressed a desire to do so. 18% said that they use AI tools daily in their personal lives, which is actually triple the general population. In a clinical setting, 50% reported using AI tools for at least one use case at work. And this is somewhat comparable to an AMA study on the usage of AI, showing that about 66% have used it at least once, or use it for a single use case at work. 32% use the AI for clinical support, things we've been talking about, ambient clinical documentation, et cetera, and over half of this group using it daily. What's striking, though, is a desire by greater than 90% have either used these tools or interested in trying them. So we're seeing a tremendous amount of openness in terms of those tools. And in this survey, interestingly, there wasn't not a difference in terms of usage between early career and later career physicians. So despite the widespread use of digital tools, and as well as AI, primary care docs have reported saying that they have very limited influence over AI tools being available in their practice, which I think we all know is going to be important as we think about adoption and acceptability on the part of providers bringing these technologies on board. And so looking ahead, there are mixed feelings about AI's impact over the next 3 years. 73% expect positive impact, including diagnostic accuracy, appropriateness of treatment plans, and improved well-being and workload. But some are skeptical that will lead to improvement in patient experience. Only 47% see a positive impact on patient satisfaction, personalization of care, and clinical patient relationship. about half of the docs are not sure, or are either not sure or unsure about the impact on job security, and 18% fearing that it will have negative or very negative impacts. And not surprisingly, 81% want more training so they can fully trust the AI solutions at work. A large majority want medical legal protections before they can trust the AI tools, want education on legal liability and malpractice risk, as well as ethical guidelines. So primary care is a bedrock of healthcare, but it's all too often underappreciated and underfunded. In 1992, a pediatrician by the name of Barbara Starfield first articulated the 4 C's of primary care, which eventually served as a foundation for patient-centered medical home, as well as designing primary care systems. And I think the concepts in this model will be fairly familiar to you. First contact, right? It's about access. It's about getting high-quality care when you need it. Comprehensiveness, the end-to-end care from health promotion to prevention to treatment and rehab. Coordination, integrating the care the care the user receives and needs with other health services and continuity, that longitudinal relationship with the care provider. But I get excited about the idea that about what AI could do to revolutionize primary care and help achieve this vision in this framing. In this framing, I don't think it's hard to imagine how AI could fit in. There is a world where people depend on AI for the common stuff. Through AI tools, general pediatricians, I believe, can become up-leveled to take care of more complex needs and rely less on specialists. It will shorten the diagnostic journey and strengthen the PCP as the medical home. This will be especially important for those who don't live near a children's hospital like ours here. And I think some of those steps are already being taken today. One of our informatics fellows here at Stanford, as well as a pediatrician, developed what we're calling Chat PPC. Our primary care clinic is in an FQHC here, where there's a range of social needs and a complex web of available services. So it's really challenging for new trainees to figure out where to send a child for a developmental evaluation, let alone know the right tool to evaluating ADHD. And so it's a custom design knowledge from the stack of pediatric primary care resources and built on ChatGPT and made nearly dummy-proof so even a physician can use it. I just want to give a brief shout out as well to some of the work we've been doing in our general pediatrics division, thinking about these really challenging areas with the vision around improving child health, especially addressing health disparities and thinking about the power of these digital tools to uniquely address those needs. We've been meeting twice a month for about 3 years and been doing a lot of work in terms of thought leadership and Rock Health, the Digital Medicine Society, and other venues. So in conclusion, I hope I was able to persuade you that it's time to shift the paradigm. Children and their families are using AI already, and they're using it to address health needs. However, AI in child health is still quite limited. AI has the potential to help us deliver the care we have envisioned and the care that we know that patients need. But it will require a boldness and a commitment from innovation to investment to implementation to broad adoption. Thank you very much.
We've got time for a couple of questions.
I want to ask 2 questions. I'm a physician scientist, so I have like 80% of the time I'm using AI like freely. I'm not concerned about anything. This is my research part, but when I go to patient care, I'm very concerned about PHI and what am I entering into the models. So wanted your comment about that. And the second is like more on the vision. How do you see a role changing as providers? I understand that we're going to use a lot. The AI might be smarter than us really soon. So because there's like exponential growth there. So curious of how do you see that?
Yeah, I think there's a couple different ways to think about it, and I'll get at your second question. Because I think when I'm watching kind of what the consumers are doing, and they're just more prepared than ever. And it's challenging, I think. The days of kind of paternal medicine, I think, are gone, where we think we know everything. The knowledge is now dispersed. It's kind of like the Gutenberg press. You know, once and I'm kind of stuck on AP European history, sorry, but that knowledge is now so freely available. There is some knowledge better than others, right? And so when they come in, then our dynamic is different. And now we have to kind of leverage our expertise in terms of not only what we've learned, but our experience that we have developed over time in seeing other patients, seeing those dynamics, right? I think that, and I think that will continue to evolve. I think that when it comes to ethics, trust, and et cetera, I think those will continue to then require that there is kind of a doctor in the loop. We may, there will be some tasks that will be increasingly offloaded, kind of more automatable tasks I think will be offloaded, but there still needs to be kind of that overread on the part of the provider. As to your first question, I don't have a great answer for you. I think that those are things that we're continuing to kind of wrestle with or nervous about. We were just hearing earlier that there's an LLM just for Stanford. There's something similar in Seattle Children's, for example, at Children's Hospital Boston, which is somewhat contained and limited for just the knowledge base internally to minimize hallucinations. It has a very specific purpose. And I think in those more sheltered scenarios, I think then there's a little more flexibility about what kind of information data that could be entered in those prompts. But I think that it continues to be evolving about how to do that better.
Thank you. My question has to do with the strategy of introducing the AI and testing it. So would QI be the right technology, scientific approach to showing its impact, to have real metrics of how it's improved, specific entities that you can measure? Or how would you do it? Or do you find that too cumbersome?
Well, I think that now we're talking about, like, especially large language models, we need to think about QI a little bit differently. We need to think about what's the data things that are being tested on. We have to think about after we utilize that technology, what the outputs look like, evaluating that technology. But that technology continues to evolve and shift over time as it continues to learn. And so we need to have that ongoing kind of QI practice once launched. And I think that's where the thinking has to be a little bit different. And there's surprisingly little there's very little regulations around this. Even in predictive AI, it's quite behind, actually. And so in large language models, there's very little from a regulatory standards perspective. And so there's a huge need to start to build that infrastructure so we can start doing these things safely and more consistently.
Hi, thank you so much. Thank you to AIMI for the last few days of learning. I'm with Doctors Without Borders International. So a disproportionate amount of our morbidity and mortality is devastatingly still pediatrics. And I share what you shared, that it's really frustrating to not see the same investment in digital health and AI tools for pediatrics. You have a kind of interesting position where you have industry, the FQHC experience, and you work for a well-funded, well-regarded research institution. How do you suggest that we collaboratively work together as stakeholders to push the needle for industry to care more about pediatrics, for them to be funding digital tools that we know are going to help this most vulnerable population?
Yeah, that's a great question. And it's something I wrestle with regularly because I don't get to do very much child health within my industry role, because it's a little bit of these different organizations, Stanford, Samsung, your organization, are going to do what they're built to do. This industry is built to drive profit, to make revenue. Hospitals have their own thing in each of those things. And so the opportunity then is to think about at what situation do those start to overlap? Or can we set the right push and pull mechanisms to incentivize those right things? So I think that when we talk about regulatory pathways for pharma, for example, so that we are actually developing medications for pediatrics, there are some of those things happening in medical device and their efforts to do that. I think we need to build the right framework to make it a little bit more attractive for them to do that. The other thing is I keep thinking about is, like, way back when smartphones first came out, we kind of skipped development steps, right? There was like no landlines in some huge swaths of the world, and then cell phones came in and just leaped over them, right? And I think what gets me so excited about these technologies is now we can leverage a Stanford physician or whatever, Boston, wherever, right? Over the airwaves, so we can assist someone in a remote area, in an impoverished area, with first-class guidance and care. And so I think taking advantage of those type of scenarios, I think could create some model use cases. And then we have to think about then how do we define success, get this aligned well organizationally with some of these other kind of entities, and then find those few things and start to kind of use that to kind of get the foot in the door and start to open broader opportunities. I was talking to someone based at Harvard who is thinking about the use of technology and then evaluating its effectiveness and usability in developing countries. And they were criticizing UpToDate, for example. As it was written in the ivory tower, doesn't really always make sense in the real world, especially in developing countries. And so looking to try to shift that to improve those technologies. And so I think there is actually a lot of value back to the first world countries, so to speak, when we have that kind of exchange. But we have to find those proof points and highlight them and then continue to expand.
Thank you.
That's wonderful. Thank you. One more round of applause, please. Thank you.